all, I would like to thank Dr. Shadajan ma'am and Dr. Poonam Goel for giving me this opportunity to speak on this very interesting but hardly ever talked subject, blastocyst transfer day 5 versus day 6. Let me have a quick overview of IVF history. All of us know the first IVF baby Louis was born in 1978, and the same year there was a test tube baby born named Durga by Dr. Subhash Mukhopadhyay, but unfortunately his work was not recognized, and it came later on to people's recognition. So in 1982, Bourne Hall IVF organized
Doctor,
first IVF conference.
Doctor,
1990s, ET slowly moved from day 1 to day 3, and in 2000, blastocyst transfer became very popular. And before I embark on my presentation, let us have a quick look at the embryonic development. These are unfertilized oocyte. This is a fertilized oocyte with true pronuclei and two polar body. Day 2 embryo with 2 cell, 4 cell. Day 3 embryo 6 to 8 cell. Day 4 embryo morula. Day 5 embryo with a blastocyst. This is expanded blastocyst with inner cell mass and outer cell mass. And day 6 embryo is a hatched blastocyst. So, as I said, that blastocyst transfer became very popular in 2000, but soon people realized there's no significant difference in implantation rate and pregnancy rate in day 3 and day 5 embryo transfer. So, this study, which was published in 2017, talked about 190 women who had undergone ICSI, and they found that the implantation rate and pregnancy rate was to the tune of 46%, 45%, and live birth rate was just 35%. So, but the study also concluded that performing blastocyst transfer may have benefits because it has acceptable pregnancy rate and morphological assessment of embryo on day 3. Sometimes you cannot be very sure about the reproductive potential, and which we are able to define more on day 5. However, Gardner et al. Reported 60.9% implantation clinical pregnancy rate if you compare a single blastocyst transfer versus a single cleavage stage transfer. Now, a very fresh study in 2023 also concluded the same. In this study, there were 266 patients included, all having undergone ICSI. 221 patients undergone day 3 transfer and 45 patients undergone day 5 transfer. You can compare the clinical pregnancy rate, implantation rate, almost similar. So, if there is no advantage of blastocyst versus cleavage stage embryo, we talk about cumulative pregnancy rate, then why are we doing blastocyst transfer? Because of certain reasons, because it improves the pregnancy rate per embryo transfer. It can be used for PGT, and this is useful for SCT and to avoid multiple pregnancy. There are certain disadvantages too of doing blastocyst transfer. The high rate of cycle cancellation. There are less embryos for freezing. There's altered sex ratio. Here I would like to say that when I was searching the literature, I found this very interesting study which talks about if you transfer more blastocysts, there are going to be more male babies. And also there are going to be more preterm birth. But yes, cumulative pregnancy rate is going to be same in either of the transfer. So, and now we are talking about day 6 transfer. Why? Let us see what does the literature say. So the literature says that the very first study is published in 2000 July when the blastocyst transfer had just started. This was a retrospective clinical study conducted in a university-based IVF center over a span of 1 year, in which all the patients who had 7 2PN embryos, they were taken for day 5 or day 6 transfer, and let's have a look at the result. The implantation rate in day 5 transfer was 69%, in day 6 it was 33%. Clinical pregnancy rate 89 and 59. But a very interesting finding which was noticed that those patients who had a spontaneously hatching or hatched blastocyst on day 6, which were unfortunately were 9% of the embryos, they had a much higher pregnancy rate of 80%. So the study concluded that hatching of embryos by day 6 is a favorable prognostic factor for outcome, and embryos that fail to hatch by day 6 may have a lower implantation potential. Further, in 2009, there was a Japanese case study which reported successful delivery following the transfer of a human revitrified blastocyst developed from a vitrified cleaved embryo, and it was a day 7 spontaneously hatched blastocyst, resulted in a live birth. Further, moving on, in 2013 July, another study published, which this was an Indian study, and where 146 women were studied. This was a prospective study of 146 women. Undergoing the first IVF-ET cycle, it was found that the single hatched blastocyst transfer group had significantly higher implantation rate, 43 versus 27.9, as compared to day 5 transfer. Pregnancy rate was also, there was significant difference, 59.4%, 45.1%, and live birth rate, all the parameters were significantly different. So the conclusion was that extending culture of expanded blastocysts by a few hours to allow transfer of spontaneously hatching or hatched blastocysts, this gives higher implantation and pregnancy rate. Going on further study, another study in 2006, this was a Korean study in which 412 cycles of single FET transfer were performed at a Korean hospital. And again, they found that the implantation rate of expanded, expanded blastocysts, hatching blastocysts, and hatched blastocysts there was a significant difference. You can see the hatched group has around 47.6% implantation rate and 44.8% pregnancy rate. So, but there is a group in which blastocysts do not hatch. They are a slow-growing embryo, or it does not hatch on day 5, but it can hatch on day 6 or day 7. So, what happens to those blastocysts? They do not perform well in the fresh cycle because endometrial receptive phase ends prematurely, but they do well when it is used for the frozen embryo cycle. So now the question is, if the hatching blastocysts are doing so well, the pregnancy rate can go up to 80%, then why this is still not a routine for everyone? Because of two reasons. Because only 9 to 26% of blastocysts actually hatch. I mean, I'm talking about the spontaneous hatching. And when you have to use a assisted hatching technique, there is a paucity about the availability of the equipment, expertise. Not everybody has an access to laser embryo hatching. So these are the two reasons this hatching thing could not be used for all the patients. Now, can this selection of spontaneously hatching or hatched blastocysts, can it be used to crack the black box of implantation? And the question is, what is black box of implantation? The black box of implantation is when even the euploid blastocyst, they fail to implant. So we know what is happening from the from the transfer to implantation. We don't know what is happening here. And this is a very recent study, thanks to Dr. Shivani. She actually shared this in the group and I studied this. So this study shows even when we transfer euploid blastocysts, the live birth rate is only 45 to 65%. So what is happening to the rest of the embryos? And it's a challenge for all of us. Now, the factors which are responsible for this loss could be with the blastocyst, could be maternal, or could be with the lab. Now, the blastocyst, the slow-growing blastocyst less than Gardner, BB great, they're not going to do well, we know. We can't do much about the age, BMI, previous history of RAF, but this is one factor where we can definitely work. This suggests if there is excessive handling of embryo in the lab, it can compromise the chances of implantation. So could it be, could it be the selection of spontaneously hatching or hatched blastocysts? Could it be a non-invasive tool to crack that black box of implantation? Why not? With this background, let me share my experience of day 6 transfer. So this patient is 32 years old, having a spontaneous abortion at 8 weeks, 2 years after her marriage. She has a history of prolonged cycle of 2 to 3 months. AMH is 12.7, like a typical PCO, FCE 40, weight is 71, BMI 29. She has bilateral loculated spill. That means both her tubes were partially blocked. Excellent semen parameters. On endometrial aspiration, there was no evidence of genital tuberculosis. She had failed ovulation induction with 12 cycles of retrose plus HMG, though she ovulated once with the recombinant FHS cycle. And in this cycle, she formed an excellent ET of 9.1 mm triple layer. The couple were given option for either laparoscopic cannulation of both the tubes or IVF. They opted for IVF due to certain reasons. We retrieved 42 oocytes, 26 out of 42 fertilized. We were able to freeze 8 embryos on day 3 and 9 blastocysts, excellent quality, excellent grade A blastocysts on day 5. I was under the top of the world, thinking that I'm going to show short success in this patient. So next cycle, we started preparing her for FET on HRT cycle. Unfortunately, ET did not grow beyond 3.6 mm and cycle had to be cancelled. So her first ET was done on Letrose plus recombinant FHS cycle, in which she formed a ET of 7.3 mm. You remember earlier her ET was 9.1 mm. We transferred 2 excellent blastocysts on day 5 and UPT was negative. Second FET was planned after hysteroscopy on down-regulated HRT cycle. Intertime GCSF was given. Again, she formed the ET of 7.3 only. We transferred 4 excellent good quality day 3 embryos and this time it resulted in a chemical pregnancy. So by the time I was in touch with Dr. Shivani, and thanks to her, I used intrauterine instillation of Ziplocs for her 9 times before I proceeded for the third FET. I was somewhere this point was clicking to me. I'm transferring good quality embryos. Probably is the problem with the ET because ET never grew beyond 7.3 in the 2 cycles. So after instillation of Ziplocs, this time she ovulated only with Litros, and she had an excellent ET of 9 triple layer. We transferred this time 3 blastocysts, but again, beta CG was negative. So I was distraught. I did an ERA for her, and ERA was receptive. Now, I was so bugged up with this case that for my next case, which had a similar profile, I planned to go ahead with straight away with a day 6 transfer. Now, let's see what happens in this patient. This patient is 37 years old with 2 miscarriages. Again, a PCO. At the age of 37, also her MH is 7.3. She has 22 AFC. BMI is okay. Cycles are regular. She has normal ovulatory cycles. Semen parameters were excellent. DNA fragmentation was only 18%. Karyotype was normal. However, she had tubercular endometritis on endometrial aspiration, and she was given AKT for 6 months before we proceeded with the ART treatment. Following AKT, her hysteroscopy SSG was done, and it showed good cavity, both tubes patent. Incidentally, she did not conceive during this period. So we did an IUI for her, and she had excellent lining, 2 good follicles, but she did not conceive. So couple, now thinking of her advanced age and hoping for a good success, couple opted for an IVF cycle next time. We retrieved 28 oocytes, 22 fertilized, and this time again I had 17 good quality embryos. We froze 8 embryos on day 3, good quality, 5 expanded blastocysts on day 5. I left few embryos till day 6, and I was very happy to get 1 completely hatched blast, 2 hatching blast, and 1 expanded blast 5AA on day 4, day 6, and all of them embryos were frozen. Planned a FET on a natural cycle. The lining was, unfortunately, it was not good, cycle cancel. Second cycle was on HRT. 2 day 5 blastocysts thawed. Here I was a little anxious. I was not sure whether these 2 blastocysts are going to hatch or not. But since I had a backup of day 6 blastocysts, I thought, let's see what happens. I will thaw these 2 blastocysts. I thought luckily both of them hatched. And now she's continuing with a single intrauterine pregnancy of 10 weeks. So inspired by the success of this patient, I thought, let me transfer now day 6 blastocysts to my previous patient. So I planned for a 4th FET and 3 day 5 blastocysts thawed. Fortunately, 1 completely hatched, 1 was hatching, and 1 blastocyst did not grow, which was discarded. And this time again, she landed with the chemical pregnancy. Now, my only hope is probably the immunological factor, correcting the immunological factor or whatever. The bottom line is that although blastocyst or day 5 transfer has become a routine practice in recent years, but clinical pregnancy rate is just 50 to 60%. Now the question is that can we, and even with the euplat blastocyst transfer, the pregnancy rate is not very high as it should be. And here the question is that what is happening to those embryos, those 35 to 55% embryos? Can day 6 transfer can offer better success rate for these patients? Probably. But one thing is for sure, day 6 transfer cannot be standard for everyone, as only 9 to 24% blast spontaneously hatch. It is certainly helpful for to a specific group of patients where there are multiple blasts and we can choose the best one to transfer, or we have multiple poor quality day 3 embryos where we are not sure about the quality. So if we allow them to grow, if you allow them extended culture till day 5, day 6, day 7, we may get few blastocysts which can be used for these patients for definitely for an improved pregnancy rate. And this is not uncommon. This we say day in and day out. So probably this is the group where there are multiple blasts. This information can be used with a better success rate. In the end, I would like to say there are still many things in IVF we cannot explain. And I feel we still do not understand IVF well enough. Thank you very much.
Day 6 is not yet for all of us and in all patients.
Yes.
So I would like Dr. Brigadier Sharma sir and Madam to comment.
I will definitely comment as far as blastocyst transfers are concerned. We had a lot of failures with day 3 transfers.
Dr. Aruna, stop share kar do.
There was a stage, I was very much depressed. So I talked with our friend Dr. Brigadier Sharma, and I made up my mind from that particular day. I am going to only transfer blastocyst, and I can say that the blastocyst transfer uh, gives me 50% success. And I say 50%, चाहे 60% भी हो, चाहे 70%, I will बोलती 50%, but not less than 50% are there. So I am very happy, and I don't want to transfer day 3 transfers. If I can take my embryos to day 5, and I'm very happy with day 5 transfers. ये hatching, no hatching, I don't know. I don't do embryology myself, so we are totally dependent on embryologists. तो हम तो भैया बोलते भाई day 5 सब ठीक है तो transfer, and I'm very happy with this. I will definitely say, and I remember very well with the Brigadier Sharma that once you start an IVF lab, day 5 transfer की बात मत सोचो, तब day 3 करो, जब आपकी लैब मेच्योर हो जाए, और तब आप day 5 के ट्रांसफर करो। और एक बार day 5 ट्रांसफर कर दिया तो day 5 ही करो। कई बार एम्ब्रियोलॉजिस्ट आपको थोड़ा चकमा देते हैं कि डॉक्टर साहब ये आज ट्रांसफर कर लेंगे, ये हो जाएगा, वो हो जाएगा। जब भी मैं उनके चकमे में आ जाती हूँ, वी लैंड अप इन फेलियर। अपने मन की बात बता रहे हो। I don't know, let Brigadier Sharma say something too.
Thank you, Madam, and nice, Dr. Aruna. You brought very pertinent point, because finally the embryo has to hatch out, then only it will get implanted. Otherwise, it will never get implanted. And if it hatches out naturally, so that means the potency of that embryo is much more than if I do artificial hatching, or if I don't know whether it is hatched or not inside the uterus. Now, there, 3-4 situations are there. One is that you get 3 or 4 eggs only, and out of that, only 2 or 3 egg cells are there. Now, whether we should go for blastocyst or we should, transfer day 3. So, under those circumstances, I may tend to transfer at day 3, because with the day 5, I may land up with no transfer.
No transfer.
So that is no problem with me, but with the patient there will be a lot of problems. They will kill you for that. I have paid so much of money and you say there is no transfer. In a government setup, yes, I would say I can say no to them, but in a private practice it will be very difficult to say कि your no blastocyst form, so I am cancelling your cycle after they have paid for injections and everything. So that is one set of patients. The second set of patients is, they have more than 6 embryos, and you know that they are hardly any fragmentation, and they would, likely to become the blastocyst. At least 50% conversion rate should be there in the laboratory. So out of 6, at least 3 should form the blastocyst. More the better, but at least 3 should be the minimum. Then only you can say that your, the lab culture conditions are good. Now, on day 5 also, you will have 2 type of blastocysts. One would be the one which are, well expanded, and or 3, I would say, the type of blastocyst: early blast, or expanded blast, and early hatching blast. So the early hatching blast, if I had to, now out of these 3, if I had to transfer, I will select the early hatching blast, so that I know that these are the best one to give me pregnancy. While the expanded blasts, whatever extra I'll be having, I would freeze them for the subsequent cycle. Now the third one, which is the early blast, I will allow to grow on another 1 day, and they will get expanded on the next day. Now they are also called day 6 because they are taken day 6, but they are not hatched out. So there is a day 6 hatching blastocyst and day 6 delayed, blastocyst. So these 2 variations would be there. Now, in case I have frozen the day 6 blastocyst, which was early hatching, so that which day I will transfer them? Will I transfer them on day 5 in the FET cycle? That means 5 days of progesterone or 6 days of progesterone? So that question would remain. And the embryos which are, say, on day 5 early blast, and I have grown them another extra day, So they would get expanded the next day, and then they are frozen. So those embryos also, which I will transfer them on day 5 or day 6. So the one which are they formed expansion later. That embryos I normally transfer them on day 5 only. Though they have taken 1 day extra to grow, but the one which are early hatching or half hatching, which have frozen on day 6, that I will transfer on day 6. So these 3-4 combinations, I think we should know that. And definitely blastocyst culture, see, up to 8 cell, it is the maternal genome which is controlling the cell division. And it is only after the 8 cell, the paternal genome also start participating. And if we are able to go beyond 8 cell, so that means the chances of implantation or normality of the embryo is much more. The chances of having a normal embryos, normally 70% of the human embryos, they have some chromosomal defect. But out of those 70%, 100%, 100 embryos which have taken, the one which are going to become blastocysts, there the aneuploidy rate is much less in comparison to the one which are in 8 cell stage. So that is why the blastocysts, the pregnancy rate is more, because many of them are euploid, more in number than in comparison to the 8 cell. So keeping this in mind, blastocyst culture, yes, you can do single embryo or maximum 2 transfer, and then one must differentiate these 3 varieties of blastocysts on day 5. So depending upon that, you plan your transfer in the next FT cycle.
Yes, sir. Dr. Shivani, you want to say something? I think Shivani is not there. And Dr.
Anybody wants to say something? Anybody? All experts.
I think people have left, ma'am. Dr. Jyoti bhi nahi dikh raha hai mujhe.
I think it had been great presentation by you, Dr. Aruna Saxena.
Thank you, ma'am. Thank you so
It
much.
definitely opened a new area, and I'm delighted. I'm very happy with the blastocyst transfer.
Sir, I have a doubt. Hello, sir.
हाँ मेघा.
Thank you, Aruna ma'am. पहले तो a very nice lecture.
Thank
Sharma
you,
sir,
Megha.
जैसे अगर हम day 5 पे thaw करते हैं, like we are thawing the embryo growing for day 6, if we're taking the embryo to day 6, so you're increasing the progesterone dose for one more day,
Sure.
especially in recurrent implantation failures. See, because अगर हमने error नहीं किया, RF patients हैं, we don't know the implantation window because we don't do error in all the cycles. So you extend the progesterone for the 6 days.
Progesterone, तो I think we should give.
तो देना ही है.
और अगर
Madam, actually, what type of blastocysts you have frozen? See, on day 5, you had an early blast.
Okay.
All right,
Okay.
which was not well expanded. And you have frozen on day 5. Okay. And you want to make it expanded and then transfer, or maybe it is hatching the next. So one day you are going to keep it outside. So in that case, you will give only 5 days of progesterone. Okay. Now the second embryo is the one which is expanded but not hatched or not hatching, and you want to grow it 1 day more to see whether it is hatching or not. Under that condition, you will be transferring, giving 6 days of progesterone. 6th day of progesterone, you will be transferring.
Yes, sir. Thank you, sir.
So I think we can conclude the meeting now. Thank you, Dr. Aruna. Thank you, madam. Thank you, Dr. Sharma sir.
Thank you, madam.
Thank you, everyone. Thank you.
We'll
Thank
be
you,
meeting
ma'am.
again
Thank
on
you,
next
sir.
20th. Thank you.
Thanks a lot.